welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website. Today, we have Dr. Sarah Schumacher, who is an ICU clinical pharmacist at the University of Iowa Healthcare, discussing the role of Fomepizole in acetaminophen overdose.
To go through my objectives today, I will summarize the mechanism of acetaminophen toxicity, analyze the animal and in vitro data which constructed the use of Fomepizole in acetaminophen overdose, and then identify patients where Fomepizole may provide a benefit. So what is acetaminophen? As pharmacists, we are all very aware of what this is. It has both an analgesia and an antipyretic mechanism of action. It is one of the most commonly used drugs in the United States, and it is very widely available for patients throughout the country, both over-the-counter and prescription. And you may even find it in a lot of unexpected products, such as prescription pain products like Percocet or Vicodin, or a lot of headache medications such as Excedrin, some cold and flu medications, and then also menstrual relief medications such as Midol. So acetaminophen was first approved by the FDA in 1951, and it wasn't until about 15 years later where overdose was recognized in 1966 to cause that hepatic necrosis. And this is where it came to be, where it was safe at those therapeutic doses of about 4,000 milligrams in 24 hours. And it is one of the most common causes of acute liver failure in the United States, with causing about 50% of the total cases. And then it also accounts for about 20% of liver transplant cases. And because acetaminophen is widely available, not all of these overdoses are intentional. There are actually 50% are intentional, but then 50% are also unintentional. So to go through the acetaminophen metabolism to help us understand the mechanisms of action for all of our different agents that we use. So we have acetaminophen, and 90% of it is hepatically metabolized into non-toxic metabolites. And then the other 10% of it is metabolized by CYP2E1 into N-acetyl P-benzoquinolamine, or also known as NAPQ. So we have NAPQ, which causes most of our hepatotoxicity in patients. But then our body has endogenous stores of glutathione, which can metabolize the NAPQ into cysteine conjugates that are non-toxic to our body. But then once a glutathione stores get depleted, this is when NAPQ can cause that oxidative stress and the mitochondrial dysfunction, which ultimately causes the hepatic necrosis. So I will go over the stages of hepatotoxicity in acetaminophen overdose, because it can help us identify patients, how long ago they may have overdosed, but also what symptoms to expect in each stage. So the first stage is from 0.5 to 24 hours. The signs and symptoms that you would see are like the nausea, vomiting, diaphoresis, lethargy, and malaise. And your laboratory values are typically normal in this stage. Only you may see abnormal lab values if they maybe if they co-ingested another agent in their overdose. The second stage is 24 to 72 hours. And this is when your signs and symptoms tend to be right upper quadrant pain, liver enlargement, and tenderness. And then this is where you start seeing those increases in LFTs and your PT and INR elevations, and also your elevated bilirubin. And this is the time where patients normally start to decompensate when they have had an acetaminophen overdose. The next stage is stage 3, which is 72 to 96 hours. And this is where those stage 1 symptoms start to reappear, such as your nausea, vomiting, lethargy, as well as confusion and bleeding. And this is where your hepatic markers peak, which is during this third stage of hepatotoxicity. And then your fourth stage is known as the recovery stage, where it might take several weeks for your symptoms and laboratory values to normalize after an acetaminophen overdose. So now to go into the treatment of acetaminophen overdoses. So you first start by evaluating the signs and symptoms of the overdose. which can help you on how long ago the ingestion actually had occurred. So to do this, we use the Rumack-Matthew nomogram, and it's used for a single ingestion. And you measure their serum Tylenol concentrations versus the known time of ingestion. And you plot it on this graph. And if it happens to be above this treatment line, that is when they are treated with the standard of care, which is N-acetylcysteine, or also known as NAC. And NAC is the only approved antidote for acetaminophen overdoses in the United States. And it does this by restoring the hepatic glutathione, which enhances the non-toxic sulfate conjugation of acetaminophen. So the question is, what happens when we have these patients who have a more severe Tylenol overdose and are plotted on the higher end of this Rumack-Matthew nomogram, where maybe N-acetylcysteine might not be enough in these patients? This is where Fomepizole comes in. Fomepizole is the only approved antidote for ethylene glycol and methanol toxicity. And it does this by it competitively inhibits alcohol dehydrogenase, which will prevent the formation of the toxic metabolites when it metabolizes ethanol and ethylene glycol. So the question is, how was Fomepizole found to treat acetaminophen overdose? The proposed mechanism of action of Fomepizole is it attenuates the formation of NAPK via CYP2E1 inhibition, so then you don't get the formation of NAPK to cause the hepatic necrosis. And it is also thought to maybe inhibit the C-Jun N-terminal kinase, which prevents the mitochondrial damage and reducing oxidative stress after NAPK has been generated. So the first case report that came out was in 2013. This was a 59-year-old female who came in with an intentional overdose, but of unknown substances. They knew Tylenol was one of them, but they were unsure on the other substances. They thought one of them was possibly methylene glycol or ethanol toxicity based on her laboratory values of being acidotic, having those AST, ALT elevations. And her initial Tylenol level was above 1,000 and the peak even almost to 1,200. And this is a pretty severe Tylenol overdose for patients. She did receive activated charcoal, Fomepizole, naloxone, and NAC due to all of these possible ingestions that she ingested. And then her outcome was that her LFTs decreased by day 3 and then normalized by day 4, and she was transferred out of the ICU on day 4. So a pretty quick recovery for someone who had a severe acetaminophen overdose. It wasn't until 2016, another journal article was published, and this hypothesized the positive outcome in this patient case was possibly due to the Fomepizole. So this is what prompted further studies of using Fomepizole in Tylenol overdose. The first studies were in mice and human hepatocytes. The first one examined the protective effects and mechanism of action of Fomepizole in Tylenol overdose in mice. Mice were treated with Tylenol 300 milligrams per kilogram plus 50 milligrams per kilogram of Fomepizole or placebo. And this trial found that the co-treatment with Fomepizole almost completely eliminated Tylenol toxicity at 6 hours, as well as it almost completely eliminated the formation of the protein adducts and then the oxidative metabolites of Tylenol. This prompted another study where they assessed if the delayed treatment with Fomepizole is still protective to investigate the potential mechanism. And so this is where they again gave the same doses of acetaminophen and Fomepizole. And then they looked at Fomepizole. They found that Fomepizole significantly attenuated the liver injury at 3, 6, and 24 hours. And it also prevented the J&K activation and its mitochondrial translocation, which does reduce the mitochondrial oxidant stress. So this first study in 2018 found that the mechanism of Fomepizole could possibly be from the CYP2E1 inhibition. And then this other study in 2019 found that it could also be due to the reducing the mitochondrial stress. So that is where both of those proposed mechanisms of action come from. Then these mice studies led to a human study, which was a crossover trial in 5 human volunteers. It was a single center study. And their primary outcome was to measure the fraction of ingested Tylenol excreted as total oxidative metabolites. And the intervention that they gave these patients was a single dose of Tylenol, 80 milligrams per kilogram, both with and without Fomepizole. So this was a crossover trial. So patients went through both legs of the study. And the results were that the co-treatment with fomepizole did decrease the percentage of ingested Tylenol recovered as oxidative metabolites in 24 hours in the urine. And there was a pretty significant decrease from 4.48 to 0.51%. And this was statistically significant with a p-value of 0.003. And this graph is to just show everyone how significant that change would be in patients, up to 4.48% all the way down to 0.51%. So then that study prompted a further case series that was published, and the case report, it was a single center study with 14 case reports that were reported between 2017 and 2021. All patients were treated with IV N-acetylcysteine and fomepizole, and also renal replacement when indicated. And whether or not patients received fomepizole was based on the discretion of the primary physician and the medical toxicologist. And the dosing they used in this trial was 15 milligrams per kilogram IV over 30 minutes. And some patients did receive additional 10 milligram per kilogram doses every 12 hours. So this case series, what they looked at in each individual patient were their peak Tylenol levels, as well as this calculation where they took the first Tylenol level times the ALT or AST, whichever one was larger at the time of the initial acetaminophen level. And this number becomes important because it is shown in literature that if this calculated value is greater than 1,500, it does show higher probability of causing hepatotoxicity in patients. So they also looked at the time and hours from the estimated or confirmed ingestion, and then as well as when fomepizole was administered to the patients. So I know this is hard to see all these individual cases, but there were 14 cases, and all of these cases did have that calculated value to be above 1,500. So these were all fairly severe acetaminophen overdoses in patients. So that's when fomepizole was being administered to patients, and not always did they get the same number of doses. So most patients did only receive the one dose, but a lot of patients also received an additional dose, as well as up to 3 or 4 doses of fomepizole. So what this case series concluded was the efficacy does still need to be further investigated with larger clinical trials, but it does say that fomepizole should be considered as an adjunct agent for Tylenol overdose. And this case series did demonstrate safety with no observable side effects in patients. To talk about the dosing of fomepizole, so it's dosed at 15 milligrams per kilogram, followed by 10 milligrams per kilogram every 12 hours as needed. And this was at the discretion of the medical toxicologist on whether or not patients were redosed. And the 15 milligrams per kilogram also comes from the indication of fomepizole being used for the toxicity of methanol and ethylene glycol. So it's the same dosing that's used in those patients. And dialysis considerations. So in hemodialysis, your fomepizole is extremely eliminated by hemodialysis. And so they do consider to give supplemental doses of fomepizole every 4 hours. But it's also to take into consideration that your dialysis is also eliminating your acetaminophen. So you may not even need additional doses of fomepizole after patients receive dialysis. And then in continuous renal replacement therapy, there was a study that looked at fomepizole being used for the methanol and ethylene glycol toxicity studied in CRRT. And they did find that fomepizole was eliminated by CRRT, but not as significant as hemodialysis. So they recommended to redose fomepizole every 8 hours instead of every 12 hours. To go on into the adverse effects of fomepizole, it does have a very excellent side effect profile, with headache and nausea being the two most common. And to take into consideration that fomepizole was approved in the early 1990s for the other indication that it's used for. And so those adverse effects were also found to be headache and nausea. So fairly excellent side effect profile for fomepizole. In summary, so where does fomepizole fit into clinical practice, which is a big question we all have. So I had a conversation with one of UIHC's medical toxicologists, Dr. Dan McCabe, and I kind of went with him with these questions on when is fomepizole beneficial in patients? So fomepizole would be beneficial in patients with extremely high acetaminophen concentrations, or if they had a delayed Tylenol toxicity and they continued to have Tylenol concentrations present. But when would it might not be beneficial? It would not be beneficial in those mild to moderate overdoses where N-acetylcysteine would adequately treat your acetaminophen overdose. And then, are there any specific Tylenol levels or LFT thresholds that they have to give when they would give patients fomepizole? And kind of talking a little bit more about this, so they did say patients above the 450 line, or some might even consider even one above the 300 line. And for those who are not familiar, the 450 and the 300 line are lines that they go off of depending on what dosing of NAC that they give patients. So they go off those lines to kind of determine if they would also qualify for fomepizole. And they would also give it in patients with also considerable Tylenol levels still present in the patient, if they still had transaminitis or if they were critically ill. And then the question comes to, when should we redose patients? So you do have to take into consideration the clinical scenario and also other treatments that the patient receives, such as dialysis. Like I said earlier, the Tylenol is excreted by dialysis, so you should not need additional doses of fomepizole following dialysis. And also, Dr. McCabe told me that they normally redose until the parent metabolites in acetaminophen serums are undetectable in patients. So this is how they would continue that in patients who maybe would not receive dialysis. And it is important to keep in mind that it is recommended only in severe cases at the discretion of medical toxicologists, and it is always used in conjunction with N-acetylcysteine. It does not take the place of N-acetylcysteine. It is always an adjunct therapy. And so going with that, that's where fomepizole does fit into clinical practice. And it is used in mainly only those severe cases where patients maybe fall on the higher side of that Rumac-Matthew nomogram. And I'm happy to answer any questions anyone may have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.